Hello, I'm Ken Cutbush. I'm an orthopaedic surgeon working in Brisbane. I'm a shoulder surgeon. I'm here today with Miss Lucy Angelini, physiotherapist, and we're here to talk about rehab and physiotherapy in relation to rotator cuff repairs. We're going to talk about prehab, what to do before the operation in preparation for your surgery. We'll talk about what to expect day one post-op when you see the physiotherapist on the ward. And then we're going to talk about physiotherapy once you've gone home, what to expect. I will see you back at 6 weeks, 12 weeks, usually 6 months and 12 months post-operatively, but certainly at 6 and 12 weeks post-op. And we're going to talk about what to expect with your physiotherapy at each stage through that process and take you through it. First of all, Lucy, could you fill us in on prehab? I know physios love prehab in preparation for your operation. It's so important, and Lucy is going to take us through that now.
We really do. Prehab can make a huge difference in your rehab outcomes. So if you're referred by a specialist for some physiotherapy before a rotator cuff repair, the things that your physio will look at are the position of your shoulder blade. So oftentimes a shoulder that's been sore really sort of sits forward. And so working on your ability to have a good position of your shoulder blade, up and back is our little catch cry. Working on your range of motion, so the length of all your soft tissue structures, and as well, if it's possible, doing some strengthening of your rotator cuff, as long as it's not too sore.
Yeah. Most rotator cuff tears are chronic tears as opposed to the acute tear. And by that, when I talk about an acute tear, that the typical acute tear to think of as someone who's been thrown off their motorbike and their tendons have been avulsed from their rotator cuff from the insertion. Those patients need surgery straight away. But most of us, when we get a rotator cuff tear, it develops over time and it's not an urgent thing to go and get repaired. You have got time to see if some physiotherapy and maybe a cortisone injection or two will settle it down. By the time we're 70, 50% of us have a rotator cuff tear, and most of us don't need surgery. So it is possible to treat a lot of the rotator cuff tears with physiotherapy and with some cortisone injections. And it's very worthwhile to do that first. Generally, you'll come to surgery once we know that conservative management isn't going to work. So at least 3 months, but often people will go for 6 months or longer, seeing if they can get the shoulder right before deciding that they need surgery. So I'd like to go and talk a little bit about surgery. With me, all the rotator cuff repairs will be arthroscopic. It's been a long time since I've done an open rotator cuff repair. We usually book about 2 hours of theatre time, expect to be in recovery for about an hour, and you'll be in the ward for one night following the surgery under most circumstances. That next morning, you'll see me. The physiotherapist from the ward will come and see you, and we'll talk about that in a moment, what they're going to do with you. The nurses will change your dressings, and normally you'll get out at about 10 a.m. after pharmacies come up with your pain meds. Lucy, could you walk us through what everyone should expect from their physiotherapy visit in hospital that first day after the surgery?
So the morning after your surgery, your physio will come round and they'll make sure that your sling fits properly. So they're fitted while you're asleep.
With you lying down, which isn't the best spot to fit the sling, it does need to be fitted with you standing up.
So the physios will refit that, and when they're doing that, they'll teach you how to take it off and put it back on yourself. So that's something that you need to know to be independent. They'll also talk to you about the best way to have a shower, the best way to put on deodorant, the best way to get dressed, all those kinds of things that you need to do every day. And then as well, they'll give you some very gentle, passive range of motion exercises. So physio is very low key for the first 6 weeks while the tendon's healing. So they're very gentle, passive range of motion exercises. So there's a pendulum, an external rotation exercise, and a little bit of a bench flexion exercise. We also keep the adjacent joints moving, so we make sure that your hand and your wrist and your elbow and your neck don't stiffen up as a result of being in the sling. So you'll be taught how to do that safely as well. Your exercises shouldn't be particularly painful. You shouldn't need to push them at all. They're just gentle exercises to keep everything moving as much as we can while the tendon's healing.
It's that healing that is the key thing. For the first 3 months, I concentrate on getting the tendon to heal to the bone. That is the most important thing. be aware in all the big overseas studies, multi-center trials, looking at rotator cuff repair surgery and looking at the re-tear rates of around 40% have been quoted. And that is not, we can get past that by being very cautious for the first 3 months. It takes 3 months for the tendon to heal to the bone adequately that we can push your range of motion. And I base that on following patients with MRI scans post-operatively at 6 weeks, 12 weeks, and 6 months. And the tears happen between 6 and 12 weeks in most cases, in my experience. So we're very, very slow with the rehab for the first 3 months. What we want is tendon healing. Now, coming back to those the things that the physiotherapist is going to show you that day one post-op, that first morning, Lucy mentioned how to put a shirt on, how to put a sling on, how to have a shower, how to put deodorant on. All of those issues have been addressed in little videos that Lucy and I have done and are on my website. Maybe not the deodorant one, but certainly how to put a sling on, how to put a shirt on, how to have a shower. Those are done as videos on my website under the physiotherapy session with Lucy demonstrating them very nicely. And so go and have a look at them, because it's a lot of, if you're worried about that, and a lot of people are, that's a pretty normal thing to think about. They're there for you to have a look at beforehand. Lucy, you mentioned passive exercises. I think many people watching this won't know what a passive exercise is, as opposed to, well, the opposite is active. Could you explain that to everyone, please?
It's really important. So passive means that it's not moving the joint's not moving under its own steam. So you're allowing gravity or a stick or your other arm to move the joint. So the muscles around the shoulder joint aren't engaged and contracting and pulling on that tendon repair. So no active movement of that shoulder for the first 6 weeks. So that's key.
Yes, and I recommend no driving and no work for that first 6 weeks. And if it's a big tear or at least a sizable tear, I'll be likely recommending that 3 to 3 months. So it's quite a thing out of your life. And please, before you have surgery, please make sure that you have got time to put aside to actually pay attention and get this rotator cuff repair to heal properly. We only want to do it once. We might then go on to talk about what to expect at the post-op visits. So typically with me, we'll have a visit at 6 weeks and at 12 weeks post-op, and then often at 6 months and 12 months as well. Depends a little bit on how everything's going with your shoulder, how big the rotator cuff tear is, and other issues. I'm just going to show up here on these screens, we've got an example of a rotator cuff tear, and it's a good example to run through. So this is an MRI scan of a shoulder. This is pre-op, this is 6 weeks post-op, and this is 12 weeks post-op. So at 6 weeks post-op, what we're seeing here is the humerus. You can see the grey cartilage layer. The white is fluid. There's a lot of fluid in this shoulder. This shoulder is very unhappy, so there's a lot of white fluid there that we can see. This is the scapula. The shoulder blade is here. This is the collarbone, AC joint, acromion, that's bone just there. This is the deltoid muscle, and of course skin just there. The rotator cuff muscle, the rotator cuff has 4 tendons, one at the front, one at the top, and 2 around the back. The one at the top, which is the commonest one that people tear, is the supraspinatus tendon, supra being above and spinatus being the scapula, so the spine of the scapula. So this is the supraspinatus here. It forms tendon, and the tendon peters out about here. The tendon normally goes across the top of the cartilage. You can see the black line there, that is bone, and then on top of that is a grey layer of cartilage which ends here, and this ledge of bone is where the tendon attaches to, and we would normally see a big tendon coming across and attaching onto that ledge of bone. We don't. This is the end of the tendon here, it's curled up here, and each one of these little green divisions is a centimetre. So this one is about 4 centimetres, 4.5 centimetres retracted from where it should be. At 6 weeks post-op, this is a typical scan, 6-week scan, MRI scan. And on this one, you now see the tendon, as I mentioned, it goes right across the top of the cartilage and comes across and joins onto the ledge of bone there. And it does in this case. You can see that grey tendon coming across there. There's a little bit of fluid in the subacromial space. Just there, that's the bursa. So it's between the rotator cuff tendon and the deltoid. There is that white line there. There's a little bit of fluid in the bursa, and that is normal for 6 weeks post-op. You can see these little screws here. People often call them screws. We call them anchors. It doesn't really matter. But if you understand, we've got to tie the tendon down to the bone, and the bone doesn't come with attachment points ready to tie down to. So what we do as surgeons, we can put these anchors in which have a suture attached to them, and we use that suture. Think of it as like a thread or a rope or something, but the suture we call it, we use that to pull the tendons down. And typically, I use what we call a double row technique. So you see one row of anchors is here, an inner row, or we use the medical term medial, and an outer row or lateral row, which is the term that we use. And so these anchors are put in here. The suture comes out through the tendon, then across the top, and then back down to the outer row of anchors, and that clamps that tendon down on that foot. We call it a footprint on that ledge of bone that we want to attach the tendon to. So we get a nice broad area of attachment rather than a single focal point. And this is exactly what we want to see at 6 weeks. This patient has been very good, and you can see it's nicely attached. What we're looking for is to see that there's no fluid between the end of the tendon and the bone. If there's been a lot of movement in that first 6 weeks, what we'll see is that tendon pulls up and we get fluid creeping in between the tendon and the bone. And of course, that's a poor indicator of success of healing of the tendon to the bone. So that's what we'll look at 6 weeks post-op, and that's what we want to see. And then this is at 12 weeks post-op. And we're seeing a slightly different MRI scan. This one shows fat here as bright, whereas this one here is what we call a T2 weighted scan, which is showing fluid as bright. But we see exactly what we want to see, which is this nice tendon coming across to the anchor points out here. And we're seeing a nice integration of the tendon to the bone, where it normally attaches to that ledge of bone there. We call it the tuberosity. Lucy, so at 6 weeks, our patient is in a sling because they've been very good and very diligent and been looking after their shoulder. They come in, we look at the scan and it's intact, and then I throw to you to take them through the rehab. What do you tell the patient at that time, that 6 week time point?
So at 6 weeks with an intact cuff, we're allowed to come out of the sling in a safe environment. So at home, coming out of the sling and sleeping out of the sling. We're allowed to start some really gentle, what we call active assisted range of motion exercises. So rather than being completely passive, as in phase 1, we're allowed to start moving the shoulder under its own steam. Gently, and then we also encourage light use of your arm for all your activities of daily living, like eating, washing, dressing, grooming, those kinds of things. But we're not allowed to lift anything of any significant weight, so not much more than a cup of tea in your hand. So we encourage light use, gentle stretching, nothing that makes it too sore. And if you're in an at-risk situation, if you're going to go out to a barbecue or the footy or something, we say probably pop your sling back on.
Yes. If it's a big tear, I'll actually be asking you to leave the sling on when you leave, or have put the sling on when you leave the house. If it's a small tear, everything's looking good, we won't need to do that. I won't be asking you to do that. We would like to keep that time in the sling to as little as possible. 3 months is an awfully long time to spend in the sling, isn't it?
Yeah. It is.
Yep.
It's more than you can imagine until you do it, I think.
Yeah, I've never done it. So then we see people back at 3 months post-op, and so let's take the situation where everything's good, which is the normal situation because people are so good and look after their shoulders so well, and we see an intact repair that's looking good, and I give you the okay to start doing proper rehab.
Yeah.
What do you tell the patients at that point?
So that's an exciting time. So normally you've got some active range of motion. So normally you can lift your arm up to 90 degrees or a little bit above, and you're externally rotating out to 30 or a bit more. And so we can start to load the tendon a bit more. So we can start some light strengthening, and we often start that with some TheraBands or some light dumbbells. And we also look to gain the last little bit of active range of motion that you won't have yet. So getting your shoulder to move enough to do what you want to do with it, and starting the strengthening process. So it's so much more fun than being in a sling. Getting it going is good. Still being really careful with anything overhead, any heavy lifting, any forceful pushing or pulling. But at 3 months is when most people are looking to go back to work, to start to drive again, to sleep properly. Life starts to be a little bit more normal again.
Yes. And normally at that point in time, I'm giving the all clear to go ahead and from there to upgrade your physiotherapy as you're able to with your physiotherapist. So my input reduces a lot at that time. Be aware, rehab for rotator cuff, it's the longest rehab of all the surgeries I do for the shoulder, And I typically tell people it's between 6 and 12 months. I rarely see the rehab being completed under 6 months. 6 months usually is the minimum, and it's not unusual for people to go through to 12 months. Particularly if you're using your arm at work, doing overhead activities. The typical example is all the tradies are like that. It will typically take about 12 months to get back to doing all of your normal duties at work. So be aware, it's not a small undertaking to have a rotator cuff repair. Lucy, do you have anything to add into what we've talked about?
I think the prehab, like the stronger you can get your shoulder before you go in, the better. So doing some physio before is helpful.
I told you Physio's not prehab.
It seems never ending, that 3 months, but once you get through that, then, it's, onwards and upwards.
Yeah, life starts to come a lot better, doesn't it? And this is my experience with shoulders, is no one thinks about their shoulder until it's bad. And then because you can't sleep, you can't work, or you have trouble working, and you can't go to the gym or do your normal pastimes, you think about your shoulder all the time. And rotator cuff tears are so common. I guess the message to give you is that there is a way forward. Your shoulder will come good. We will get you a shoulder that you can go back and do everything with, and a shoulder that you stop thinking about, and that's a good thing.
They can be quite achy in the first 3 months, and so that's very normal. Sleep can be disrupted, all those kinds of things, but it gets better.
Yes. Yeah, life does get better. Thank you for listening to us. Look forward to talking to you in the next one.